Hello, everybody. I'm Joy Swift. Thrilled that you're joining us in the board review course. So I'm going to cover today virtually ophthalmology. We'll do this in two parts, the anterior eye and the fundoscopic exam. Because this is being recorded ahead of time, we won't actually have you do the live polling because it'd be impossible. And so, but I will pause with each question, and then I have a follow-up answer slide. And what you will have in the handout is a slide set that does not have the answers after each case, but has them at the end. So I hope this is fun. Ophthalmology is probably an area that many of us are not very comfortable. So I'm going to focus on some high points and hopefully give you enough details that for the 2% of ophthalmology questions on the boards for primary exam, that this may actually take you a long way to that. Thanks to Whitney for operating the slide set and the video for us. Okay, let's dive in. So first of all, when I get help from the ophthalmologists about the cases and content periodically, one of them once said, well, you've got to show them this image. And this is about the level of sophistication that many of us have with the eye. So the various parts and, you know, what are the translating these, the colored part, the iris, the lash part, the round part, the pupil. So anyway, it's kind of entertaining, and we won't walk through all of these. But if you feel like your level of comfort with this is modest, you're not alone. So let me just ask you, what is this image? So this is something that became popular quite a few years ago. Still sometimes is done, is not legal. It's actually colored circular lenses. And these are available on the internet. Used to be called Lady Gaga eyes, and essentially is giving this impression of this very wide-eyed special look. So just to be aware of in the world of the eyes as an important cosmetic area, people are trying to do things. So the other things separately, sometimes we'll see patients who use tattooed eyeliner, eyebrows. There's medication that can increase the lashes, but can cause some permanent staining of the lid area. So it's just to be aware these things kind of pop up. The boards aren't going to go there, but I think it makes it interesting. Case 1. A 79-year-old man comes to your primary care clinic for routine follow-up. His son is concerned about his father's ability to pass an upcoming driver's license exam as he recently was diagnosed with a cataract. He often drives alone to the store. The patient thinks his vision is fine. On exam, visual acuity is 20/30 on the left, 20/50 on the right, and with both eyes, 20/30. So my question for you is, what is the best response to whether this patient can safely drive? A, he should not drive until cataract surgery is completed on the right eye. B, he is fine to drive only if there's another rider with him. C, he needs visual acuity 20/50 or better to pass his vision driver's test. D, he needs visual acuity 20/40 or better to pass his vision driver's test. Or E, none of the above. So think about that for a few seconds. And the important objective of this case is, can we let patients leave our offices and go to their cars when they have these conditions? So the right answer here is, in most states, the visual acuity when the testing is done has to be at least 20/50 or better to pass the vision test. So this patient, if we just go back, with both eyes, he's fine. His right eye actually does meet criteria for getting surgery. Okay, so the impaired vision definitions, there's really limited exact consensus on this, but blindness is pretty well established that vision worse than 20/200 with best lens correction meets that criteria. And there's very extensive blind rehab programs. Significant vision loss means World Health Organization uses visual acuity worse than 20/60 with the best lens correction I mentioned in the US, the states, most states are 20 over 50 would fail if they're worse. But many ophthalmologists will say it's actually should be individualized and it depends on how much is impairing function. So if I have a computer programmer or software engineer who really needs fine vision, they might have difficulty if they're 20 over, 30 to 40. Some of my more elderly patients who are no longer driving for other reasons may actually do okay when they're at 20 over 40 or even worse. Um, okay, cataract prevention. Just to talk about this for a moment, diabetes does increase the risk of cataracts if there's poor glycemic control, association with severe diabetic retinopathy, or prolonged duration of diabetes. And then as individuals get older, research suggests that oxidative stress has a role in formation. However, trials of antioxidants such as vitamin E have not been shown to actually be beneficial. And interestingly, there's some older data that prolonged use of topical facial intraocular steroids or large doses of inhaled steroids can be associated with cataracts. There's about a 2 to 3-fold relative risk. So just a few pictures here, exactly how the boards will go with some things like this, I'm not sure, but just so you have some background. So this patient, we're looking at the medial epicanthus here. On my screen would be to the right and the bridge of the nose. And so the picture was taken for the purposes of this thickened, yellowish deposits that are occurring on both upper and lower lids. And you probably have seen those before. So those are xanthomas or xanthelasma, so seen with hyperlipidemia. But when the picture was taken, actually notice this patient also had blepharitis or debris on the lids. Here's another picture of an upper lid, and at the base of the lash, you see this pustule. So this is actually an external hordeoleum or a sty. And here's pictures of internal hordeoleum. I'll show you the anatomy in a moment. So this one on the upper picture shows on the inner upper lid. And these are really enlarging areas, lesions that can end, or collection that can end up then becoming infected and then can drain either inward or outward. On the lower picture, you see a little central punctum there. So this would be an internal hordeoleum. So a little bit of information about this condition. So hordeoleum, localized redness, pain, swelling on the upper lower lid, usually is a superficial staph abscess. The sty, the site of infection I mentioned around the lash follicle, can also have blepharitis associated. The internal hordeoleum is the meibomian gland structure, gets an abscess. And then warm compresses, antibiotics, oral for internal, ointment for external every few hours, and excision if it does not improve. Boards won't say this, but I will say that I have a current patient who actually had what was thought to be a hordeoleum, persisted, and was a sebaceous carcinoma that ultimately needed to be excised very widely. So there is in the ophthalmology guidance that if these persist or a solid mass in the upper or lower lid, that needs to be investigated. So this is a question about management. Which topical medication would you select for blepharitis? So we're talking about the debris and infection of the lashes. A, erythromycin 0.5% ointment. B, sulfacetamide 10% solution drops. C, aminoglycoside, either Tobra or gentamicin. D, quinolones, such as ciprofloxacin. E, triple antibiotic solution, as with this combination therapy. So ointment, erythromycin ointment, sulfa drops, aminoglycoside drops, quinolone drops, or antibiotic solution for blepharitis. So the correct answer here is erythromycin. And It seems like you might be thinking, well, we should get more complicated than that. Many of these patients will get better with essentially just dilute baby shampoo, cleansing the lashes, and just the hygiene of the eye and the skin. But the ointment helps to stay on the lashes. It does blur the vision a little bit, so that's not usually, if it gets in the eye, it's not usually great, but it does actually stay on the lashes. Case 3. A 37-year-old woman presents for emergency department evaluation of left eye swelling and facial erythema present for about 18 hours, preceded by sinusitis with purulent nasal drainage for 5 days. She has noted a low-grade fever. So see an image of her. Temperature 38.8 centigrade, blood pressure 104/70, heart rate of 92. And we can see, I don't know if you can see my arrow, but the swelling of the eyelid is present with erythema extending from the upper lid to the lower cheek. This is a pretty significant infection. And my question is, a patient who's febrile, has had recent other symptoms of sinusitis and purulent drainage, which physical exam finding is most helpful to distinguish post-septal cellulitis, which is orbital cellulitis, from pre-septal or periorbital cellulitis, which is more superficial? So the question really is, which exam or feature will most help us say, is this a deep orbital cellulitis or a more superficial periorbital cellulitis? A, fever. B, impaired extraocular movements. C, difficulty opening the eye fully. Or D, purulent nasal drainage. Or E, severity and extent of cellulitis. I'll give you a moment to think about that. So this is an important evaluation point, and that is impaired extraocular movement. So we should be assessing that in a patient. So here's my anatomy photo showing some of the earlier landmarks. But I want to focus here on, Whitney, can you see this when I use my arrow? Okay, great. So this is the orbital septum, and this distinguishes structures deep to this is infection deep to this is orbital cellulitis, more superficial, getting into some of the more superficial muscles as well as the lashes and the meibomian structures. That is periorbital or preseptal cellulitis. In blue are the meibomian glands, which is the site of involvement of an internal hordeoleum. And then we see the lashes, and here's the lens of the eye. Okay, so you might say, well, what if I just look at the patient? Can I tell how deep this infection is? It's really hard to tell. Preseptal cellulitis shown here, where just as much redness, swelling, but again, a bit more superficial and earlier in the course. So orbital cellulitis is considered an ophthalmologic emergency. So presentation, as we just saw, red, swollen lid and conjunctiva, may have proptosis, which due to the infection deep in the globe is pushing the orbit outward, and then may have optic nerve involvement as the nerves get trapped in those infection and inflammatory areas. So the extraocular movement impairment helps to distinguish these, as the case just demonstrated, because the muscles get trapped in, as I mentioned, the inflammation in all of the soft tissue and tissues of the eye that are being involved with the cellulitis. So the etiologies might be primary, such as trauma, or secondary, as in this patient having a history of sinusitis. Maybe they've had recurrent, and this is now progressing. And the organisms are a variety: staph, strep, Haemophilus. A classic question that boards could ask is, what type of infection would you expect in a very poorly controlled diabetic patient or a patient who's very immunosuppressed? Used to be called mucormycosis. Now it's called zygomycosis. I always remember that because of the orbit of the zygomatic arch of the orbit. So complications may lead of orbital cellulitis may lead to cavernous sinus thrombosis, meningitis. So the treatments, as I said, really need to have emergent care, admit, culture, antibiotics, a CT scan, or to look at the extent, or MRI, ophthalmology, and ENT consultation, and likely will need surgical debridement. So here's just a break from all those dense slides. Orbital cellulitis, clinical pearls. I'm hearing myself, so okay. So just a few pearls about orbital cellulitis. As I mentioned, an ophthalmologic emergency. One of the basic exam points is to see if there's extraocular muscle involvement impairment, because that means that the infection and related inflammation and fibrotic changes are trapping the muscles. And if you're not sure, scanning the patient. Okay, I hope I'm not going too fast. Case 4, we're going to move on to thyroid ophthalmopathy. This patient presents with eye symptoms and occasional palpitations. She notes that her eyes look different and that at times she has double vision. So exam, she has thyroid enlargement, thyromegaly, and her eyelids are retracted, meaning that they're pulled upward. On eye exam, we're seeing her after asking her to look upward. So take a good look at the position of her eyes while she's looking upward and the periorbital areas. Hopefully you're getting a good look at that. Which of the following is correct? A, the patient has weakness of the superior rectus and oblique muscles. B, this is also called lid lag. C, the patient may have multinodular goiter. Or D, the globe is pushed outward and she has exophthalmos. So this is a little bit tricky. So I hope that you could see that the patient's left eye is moving up, but the right eye is just sitting in position, and that it looks like there's almost a swelling or a puffiness of both the upper and lower lid areas. So what she actually has is Graves' disease and exophthalmos. Again, definitions of the globe being pushed outward. This is not seen in multinodular goiter. Those deposits of what looks like puffiness is actually mucopolyglycans, and it has to do with some, interaction between the eye and the thyroid tissue. So this is called lid. So it's not lid lag. It's not actually weakness, of the muscles, but it mimics a weakness as those muscles are trapped. So this shows lid retraction. So we're looking here at the eye, and you see the iris, the limbus edge of the iris, and the lid. So normally, I don't know if my next picture shows, nope. Normally the lid, you can look in the mirror at yourself later, sits 2 millimeters below the limbus edge, so approximately right here. However, when we are excited, animated, or in the case of lid retraction, our lids will be pulled upward and you can see white above the limbus edge. Now, in the case of exophthalmos, the lid retraction can, be easily reversible. Whereas exophthalmos is going to be much more of a permanent process, although there are some therapies now. So here's an example of lid retraction, and in exophthalmos, this is not a before and after. These are two different individuals, but you see that very frightened, staring look of the woman on the left of the screen. That's called Dalrymple sign, some roundsmanship there. And then you see the asymmetry that can occur in the patient on the right. So so exophthalmos can be measured with an exophthalmometer, where they actually look at the position of the globe with the patient sitting upright. And so this is lid lag. So when we're examining the patient and asking them to follow our finger up, sideways, and down, we're also looking as their eyes going down to see if the lid lags behind, which can be seen in lid retraction and certainly in exophthalmos. And you see in this patient with exophthalmos how the globe is lagging there. It's pulled back. Okay, what is the most common ocular finding in Graves' disease? A, conjunctivitis, B, anterior uveitis, C, increased intraocular pressure, or D, pupils are unequal, or E, exophthalmos. So we've been talking about exophthalmos. Question is, are there any other conditions that are more common than that? So hopefully thinking. So the correct answer here is conjunctivitis. And you can see from these prior examples that there's an excessive amount of the conjunctiva and sclera that are exposed because of the lid being pulled further out, so the tears aren't going to lubricate the eye as well. And so conjunctivitis, that sense of the eyes feeling gritty, is actually an early finding. So this is an example of a patient who has chronic exophthalmos and has what's called chemosis, where there's just this edematous looking tissue in the anterior eye just from the excessive exposure. So hopefully we would diagnose hyperthyroidism prior to this development, but my understanding is that exophthalmos and these depositions can happen pretty of tissue of these mucopolyglycans around the eye can occur relatively early in the onset of Graves' disease. So thyroid pearls. So I haven't gotten to that part of the talk yet. I'm not sure why I'm hearing a comment. Anyway, hyperthyroidism, clinical pearls. So the normal position of the lid is 2 millimeters below the limbus edge. The white conjunctiva seen above the iris suggests that there's either lid retraction, which may be more transient related to the adrenergic stimulation, or actually exophthalmos with this infiltrated process that occurs with Graves. All right, so moving on, just briefly to talk about this. So this woman comes into the emergency department because she looked in the mirror and noticed that her eye was red. So I've got a close-up picture here. You can see maybe that there's a pretty sharp demarcation between the red aspects of the conjunctiva and the surrounding eye. So this is a subconjunctival hemorrhage. And these are actually relatively common. They generally do not require a workup. However, I have seen here's a much more severe example of a subconjunctival hemorrhage. Can take at least a few weeks for that hemorrhage to completely resolve. Can occur spontaneously, can be in the setting of trauma. We have seen some cases of patients with a low platelet count from a few different conditions that that then presented with a subconjunctival hemorrhage. So I do actually take a look at the exam to see whether there's any other signs that they might have a bleeding disorder. However, there's no recommendations for a simple subconjunctival hemorrhage, as in especially the prior image, to do any lab testing or platelet count checking. All right. So now we're moving a little bit deeper into the eye and looking a little bit more at the conjunctiva and other structures. So case 6, you're evaluating a 39-year-old man in the emergency department who complains of red eye pain bilaterally for 2 days. He's had no recent upper respiratory infection. Past medical history includes an arthritis with low back pain and joint stiffness. Did have an episode of conjunctivitis in his left eye and a diarrheal illness requiring treatment the past year. And he's on an anti-inflammatory ibuprofen. So here's a picture of him. So He's not jaundiced, although he kind of looks yellow. On exam, he's uncomfortable, afebrile, blood pressure 146/92. His visual acuity, both eyes checked, 20/40 bilaterally. Pupils are 3 millimeters and reactive, and eyes are tearing, and you see the marked injection in both eyes. So close up, his eye might look like this. So I want you to pay close attention to that pattern of redness, looking again at his history. So he complains of eye pain in both eyes. It's been of acute onset, no other new symptoms of infection, and he has a prior history of arthritis and low back pain. He has visual impairment, 20/40, with checking both eyes together. So, what is the most likely diagnosis and recommended treatment of this patient? A, he has mild bacterial conjunctivitis, treat with ophthalmic antibiotic drops. B, he has viral conjunctivitis, treat with lubricating drops such as isotears, natural tears, there's a variety for irritation. C, iritis or anterior uveitis, treat with steroids. D, keratitis, so infection or inflammation of the cornea, treat with acyclovir. So take a moment to think about his case and pick one of those. So in our actual course, when we do this with live with asking questions, the vast majority of people pick A or B. And that's often our first thought when we see a patient with an acute red eye. However, this patient actually has iritis. And what I'm hoping in the next bit of time as we go through these different types of infection and different levels of severity, that you get a sense of how different these things present. So iritis was the answer here, and the patient needs to be treated with topical steroids. So eye pain pearls at this point. Not all red eye is benign conjunctivitis, distinguishing distinguishing eye discomfort from true eye pain. And then if you see a patient who actually has pain, not just the grittiness or irritation and a red eye, to me, they have iritis until I rule out, any red flags on history or exam. And if we suspect iritis, an urgent ophthalmology referral. And one point that we'll come back to, but I hope you appreciate it, is that the patient had circumcorneal injection. Maybe I can even go back. So this is redness of the eye adjacent to the limbus edge because of the involvement of the uveal tract structures, rather than more peripheral redness, which would be expected from viral or bacterial conjunctivitis. So that's called ciliary flush. You've probably heard of that. So case 7, what is the most common bacterial cause of acute conjunctivitis? A, Staph aureus, B, Strep pneumococcus, C, Haemophilus influenza, D, Chlamydia trachomatis, or E, E. coli. This probably is sort of a gimme of bacterial causes, would be staph. So let's go back to viral conjunctivitis, which is probably the most common cause of red eye. And here we see an example in the photo of lateral injection, very clear, adjacent to the iris. So this is the classic pink eye, often have other upper respiratory infection symptoms. They may have adenopathy of the preauricular or submandibular regions. There's lid edema, and we'll look in a moment when we avert the lid for serous discharge and follicles, for follicles. The serous discharge is often sort of a watery, a little bit yellowish discharge. Adenovirus is the most common viral pathogen, and it is actually contagious for 12 to 14 days. So careful hand washing, just topical lubrication, because the eye does feel very dry, and this tendency to rub it, which then can cause infection on the other side. Here's a close-up of that pattern. So just looking at that, it's hard for me to see whether that's bacterial or viral. So some of the other associated viral might be clues, but in bacterial, we should see more discharge. So when we avert so one part of the exam that's very important is eversion of the eyelid. And there's techniques for just taking a Q-tip swab and rolling the upper lid and just taking a look at that everted inside lid. The reason that's important is that viral conjunctivitis is associated with whitish gray precipitates or follicles on the tarsal conjunctiva. Bacterial conjunctivitis or allergic conjunctivitis may have redness or hyperemia, but really are not going to have these other changes. And the tarsal conjunctiva should be perfectly normal in iritis because that structure is not affected in iritis or anterior uveitis. So here's a little bit of illustration of follicles of the conjunctiva. You see sort of this faded grayish area, and these are actually lymphoid precipitates, and this is on the inner aspect or tarsal conjunctiva. So the clinical pearl here for viral conjunctivitis is the most common cause of viral conjunctivitis is adenovirus, which is highly contagious. So conjunctivitis, so bacterial, when it's mild, may just be this lateral redness. As I said, there's usually going to be a mucopurulent discharge that's more prominent than the serous discharge of viral. Haemophilus influenza, M. catarrhalis also associated. So the treatment is topical antibiotic drops every few hours while awake, and then 4 times for a few days, 2 days, then 4 times a day until 2 days after the eyes clear. I think it is important to have our nursing staff make a quick call to the patient to make sure that they're improving, just in case we might have missed something. So before we get to this question, I want to make the point that bacterial and viral conjunctivitis should not affect vision. So the patient in our case who had a visual acuity, both eyes together of 20/40, really we wouldn't have an explanation for that in conjunctivitis. So that was a major clue. And then the pattern of redness, as well as the arthritis history. So which topical medication would you select for mild bacterial conjunctivitis in adults? A, erythromycin ointment, B, sulfacetamide drops, C, aminoglycoside drops, D, quinolone drops. So in boardsmanship, there's usually at least a couple of answers that are plausible, and what you want to do is pick the one that is the most correct, but there may be another question that is partially correct. We'll cover this more in test-taking strategy. So the correct answer here is sulfa drops. And the reason for that is I touched on this only briefly. We were talking about blepharitis, where erythromycin ointment would be preferred to keep on the lashes. Ointment does blur vision for 15 or 20 minutes, so a person can't drive, read immediately, but it is preferred for children or difficulty getting drops in the eyes. Aminoglycosides are sometimes used. There can be some cases of toxicity to the corneal epithelium and maybe a reactive keratoconjunctivitis. And quinolones, although technically correct and would be effective, are considered really too high intensity for this therapy. There would be concern about resistance, high cost, and we want to save those for keratitis and corneal ulcer. Severe bacterial conjunctivitis is this awful looking image as seen with gonorrhea and chlamydia. So this is an ophthalmologic emergency as well. Cultures for gonorrhea, intramuscular and IV ceftriaxone, chlamydia, probably doxycycline would be the preferred choice, at least in other conditions, more effective than azithro. So hopefully you can distinguish in the exam of the eye that this is a very different discharge than what we've seen before. Allergic conjunctivitis, I want to just touch on population. So there's mild ocular symptoms that respond to allergy avoidance. Topical antihistamines, no role for oral antihistamines, and long-term treatment, such as with a mast cell stabilizer, H1 blockers. So the clinical pearl here, which I didn't do a case of, allergic conjunctivitis is best managed with a topical antihistamine short-term, and oral antihistamines are less effective. So case 9, 44-year-old patient comes to the emergency department with vesicular skin lesions on the face present for 2 days. He denies eye pain or ocular symptoms, but the skin lesions are painful. And I will point out this is only involving the left half of his face. So acute vesicular lesions involving the face, nose, lips. He denies eye pain or any eye symptoms. So I think you recognize that this is most likely, it looks like herpes zoster. So my question is, which of the following is correct? A, Hutchinson sign, lesions on the tip of the nose, is negative, thus there's no eye involvement. B, the absence of eye pain makes herpes keratitis unlikely. C, the incidence of zoster ocular complications is unrelated to severity of the rash. D, this patient needs antiviral therapy within 7 days to reduce risk of postherpetic neuralgia. So herpes keratitis, which can be seen in herpes simplex and herpes zoster, is very interesting in that both of them actually have really no eye pain. So I'm not sure why there's a hypoesthesia of the cornea, but that's true. So B is not right. Hutchinson sign, I'll show you an image. We were all taught that if you have involvement of the first branch of the ophthalmic nerve, so fifth cranial nerve, first branch, that there would be eye involvement. However, if that's not present, it's not helpful. And you can have very few lesions and have eye involvement. So about half of patients who have herpes zoster on the face actually do have some changes in the eye. So that's why this patient does need one of the topical, so acyclovir, valacyclovir for herpes keratitis. There's D was another option which you might have thought about as to whether the patient should be treated with antiviral therapy to reduce the risk of postherpetic neuralgia, and that actually does not is not considered the most correct answer here. So if the reason this is important is that the patient by the trials needs to have antiviral therapy initiated within preferably 48, but at least by 72 hours of the onset of the rash to reduce the risk of postherpetic neuralgia. So that's why that was not correct. So this is an example of a patient who had very severe zoster, clearly involving the eye. The nose is clear, but it's more in the upper eye region. Patients who have herpes simplex keratitis often will have a little outbreak of vesicles in the region. So clinical pearl here is that anytime there's reduced visual acuity or any sensation, the red eye in the an eye that's red needs urgent ophthalmology referral. Not directly relevant to this case, but they certainly can, in zoster, can have reduced visual acuity. So slit lamp exam, which historically was a time-honored part of the exam, still very important for ophthalmology. You can see here in the picture, maybe with the slit lamp and using a rose bengal stain, hopefully just above the arrow, you can see this faint red kind of branching area. So this is showing involvement of some of the corneal layers. And also can see the layers, so aspects of the iris as well. So for ophthalmology, this is valuable in localizing, and different types of conditions have different presentations. However, in primary care, it's not clear that in general internal medicine that we are good enough at using the slit lamp exam. I know of only one study that's now over 20 years old, where it's a British study where they had 100 consecutive patients with a red eye, and going through all the history features, exam features that we just talked about, asking the practitioner which features were most important in determining whether you did an ophthalmology referral. And in none of the cases was the slit lamp exam what decided it. It was things that we were talking about, such as the pattern of redness, visual acuity, other aspects of the history. Okay, briefly mentioning this because of association of red eye with contact lenses. A 21-year-old college student presents with a red left eye. He wears extended wear contact lenses. Which organism is most likely the source of the infection? Staph aureus, Strep pneumoniae, Haemophilus influenza, Pseudomonas aeruginosa, or Candida albicans? So this is one of those, if it seems obvious, it's probably right. So I'm expecting 99 to 100% of you got this one. Clearly an association of Pseudomonas with contact lenses that are in for extended period of time, and other aspects of hygiene around those contact lenses. So keratitis, mention here the other organisms that can be seen. This does require an ophthalmology emergency. There might be some other non-infectious conditions that are not directly related to the contact lens, or could be some trauma related, such as abrasions. The frontline urgent and emergent evaluation is just you sort of considering the differential, but would expect to see red eye, impaired visual acuity, pain, and photophobia. So this is one of those conditions, keratitis, that is associated with pain if it's not herpes zoster or shingles. So the evaluation by ophthalmology would be corneal culture if a severe infection, and then this is where you would use the quinolones to treat. Usually would avoid steroids. So I'm showing this question mainly because I want you to be used to this type of question, which can be a little bit confusing and time intensive to review when they give us lots of different combinations in the choices. So the question, which of the following features of a patient with red eye would be most consistent with iritis? A, vision loss, eye pain, lack of discharge, and circumcorneal redness. B, vision loss, small pupils, mucopurulent discharge, and circumcorneal redness. C, small pupil, eye pain, mucopurulent discharge, and lateral redness. D, eye irritation, large pupil, lack of discharge, benefit with an anti-inflammatory. So usually with this type of a question, I'm looking to see, is there anything in these choices you can immediately eliminate? Wouldn't expect the discharge, so eliminating B and C. The pupil is what distinguishes these issues, but the eye pain. So the correct answer here is eye pain. And in most patients with iritis, the pupils will be small. So here's another example of ciliary flush in a different patient. Again, that very intense circumcorneal redness. Vision is usually impaired. I saw one patient one time who actually had gone to the store to get an eye patch because his red eye was so uncomfortable, and actually had vision of 20 over 100. So unlike conjunctivitis, I mentioned eye pain, and you can have mild photophobia in conjunctivitis, but it's not going to be as severe as this. Small pupil, eye injected, including at the limbus edge. We just mentioned that. And then another important feature of iritis is looking for associated disease. So in 60% of patients, no cause identified, but may occur in association with HLA-B27 expression. Either may or may not be linked to ankylosing spondylitis clinically. Maybe an isolated eye disorder can occur after surgery or as an adverse reaction. So a classic paper that gets quoted every time we talk, a person talks about iritis, was an ophthalmologist in Portland who actually looked at a series of patients referred for concern for iritis, a variety of different types of conditions. I mentioned AS, but rheumatoid arthritis, reactive arthritis, psoriatic, and then sort of recurrent or even chronic systemic infections and sarcoid associated. Malignancies really not associated with iritis. So if you have a patient who has a history of rheumatoid arthritis and they have an acute red eye, it's, just really makes that much more concerning. So the treatment, I won't belabor this, is topical steroids. The reason this is so important to make this diagnosis, and you might say, why did you spend so much time on iritis and so little on conjunctivitis? Because occasionally it can be self-limiting, but you can get what's noted here, posterior synechii or adhesions between the iris and the lens capsule, cataract, glaucoma, chronic iritis can develop, and then very importantly, vision loss. So there's been several studies. Here's one that illustrates this pretty clearly. So patient study of 154 patients, visual acuity was minimally changed in 70%, but the outcome ultimately better than 20/60 in 85%, 20/60 or worse in 10%, and legally blind in 5%. So you can see that 15% of these patients may have enough chronic injury and changes not to be able to drive. So I'm just going to keep going. The pearls are pretty self-evident. You can look at that. So just a couple more cases on anterior eye, and then we'll spend about 20 minutes on fundoscopy. Patient was admitted on a Friday night for mild dyspnea after running out of his inhalers days after being discharged from a skilled nursing facility for alcohol intoxication. Past medical history, had kind of an ill-defined vasculitis, was on chronic prednisone, 40 milligrams a day. When on exam, irritable, but in no apparent distress, and his vision was not impaired. One day later, he complained of discomfort in his right eye. On exam that day, he had trace conjunctival injection. The tarsal conjunctiva was clear. His visual acuity was 20/30 in the right eye and 20/25 in the left. The following morning, so now 48 hours after he presented initially with his inhaler request, is that he says, I can't see. An exam we'll look at, but on vision, he has right eye, has light perception only. So marked vision impairment in his right eye. So patient with rapid loss of vision in the right eye, on exam, we see this opaque lower anterior eye with a fluid level. What finding does this patient have? A, hemorrhage that's subconjunctival, B, hypopyon, C, hyphema, D, hyperkeratosis, or E, hyperbole. Just keeping you awake there. So you probably can narrow it to one of these H's in the top three. So this condition is a sign of pus and inflammation in the anterior chamber. This is a hypopyon. This is essentially the diagnosis of endophthalmitis. Just to show you what a hyphema, which is blood in the anterior chamber, would look like, this is really related to trauma of some kind. Don't see any other obvious disruption to the globe, but this patient on exam had a tear right at the edge of the iris and the limbus edge. So endophthalmitis is a very concerning condition. So the diagnosis is an inflammatory process involving an ocular cavity, often synonymous with infection involving the vitreous humor, so the posterior aspect of the eye, can be exogenous, such as post-op after surgery or trauma, which is what we think happened to him, that he had had some falls. Essentially, his eye was infected. Can also be endogenous, where there's hematogenous spread of infection from another site, and I've listed several here. So it's usually bacterial, but occasionally fungal. And the most alarming part of this is that despite a very aggressive workup, as soon as that hypopyon is seen or there's any sign of vision impairment, along with it is aspiration of pus, IV and intravitreal antibiotics, looking for any sign of systemic infection that may have seeded the eye, evacuation of the pus, steroids sometimes because there's such severe inflammation, but that's controversial. But the prognosis and outcome is really usually very poor because, and blindness, because it starts with infection in the vitreous or back of the eye, and then by the time we see that hypopyon, it's very advanced. This patient, I was able to visit in eye clinic when the ophthalmologists were seeing him 2 weeks after he was discharged, and he had no recovery of vision, unfortunately, but the exam does illustrate important points. All right, so this is kind of just a fun case at the end of a long talk. Case 11, I think that's 11. Excuse me, case 13. An 11-year-old patient is evaluated for an acute red eye. The patient's often outside and had an eyelid injury at age 2. On exam, we see fluorescein stain, sort of this hazy bluish green area of almost the entire anterior eye. What is the most likely diagnosis? A, dry eyes or keratoconjunctivitis, B, bacterial conjunctivitis, C, viral conjunctivitis, D, a corneal abrasion, or E, iritis. So it doesn't quite look like all the cases we've been talking about with iritis. So you probably are like, what is this? First time I showed this picture, somebody asked if it was one of my cats. No, but it is actually a picture of a horse with a corneal abrasion. So Manna had, here's a picture of Manna going to see the vet, and the vet trying to remove some of the inflammation, and patient had already had a course of antibiotics already, but now trying to debride some of this tissue on the cornea. And you see with the fluorescein stain just the huge extent of this involvement. So every time I go back to the family ranch, it seems like I get to go to the vet for something. So this is a picture of Manna, a beautiful horse. She's a little groggy, so wide-legged, not very graceful, but here's she with her mother. So anyway, that's my best example of keratitis. And just a few things about corneal abrasions and injury to the eye. The extent can be extremely small and very minimal disruption of the epithelium of the cornea, or can be extremely extensive, as in this case. So the kind of extent, I think ophthalmology does need to see those patients, and then their frequency of follow-up will depend on what this looks like. I didn't include a slide about, whether about trauma and patching the eye. But in general, patching just makes things worse. And so we just want to cover the globe if there's any sign of trauma or injury, and then just get them to ophthalmology. Dry eyes, we won't touch on in depth today because of time, but I do want to say that there's a decreased quantity and quality of tears with aging. This is a patient, again, with a rose Bengal stain, and you see these sort of stringy precipitates that are occurring. So the eyes, not only do they not produce tears, but they don't cleanse as well either. The classic Schirmer's test by ophthalmology, a stain to see the extent of dryness. And then just a little bit here about LASIK. I don't know that boards would go there, but RLE, LASIK, just extremely common procedures now. I've generally thought those are not in the realm of primary care. However, if a patient does tell me that they are going to see someone for LASIK procedure or other, I think it's important to ask about whether or not there's there's been a careful review of what the care is going to be, the follow-up. Are there any risks that maybe this procedure might be more likely to cause problems? About 4% of patients after LASIK will have persistent problems with dry eyes, potentially some vision changes, and things like pre-existing dry eyes and large pupils make that worse. So hopefully that gives you at least some background information about the anterior eye, and that some of this was a review and maybe a bit of it new for you. So now